tonight, I'm going to talk a little bit about cancer, fertility, and family building. So I am the program manager for fertility preservation here at Northwestern Medicine, primarily in the downtown office, but do offer fertility preservation services throughout all of Northwestern Lurie's cancer centers all across the greater Chicagoland area. And then I also actually answer the national hotline for fertility preservation. It's called the FERT line, rings right to my desk in Chicago. And that allows me to help patients and providers really and truly all over the country to kind of determine, what's going on with current status, what treatments are available, and then also help refer patients as needed really across the country. So I do have a couple of disclosures. Let me get to that. So I've given some talks and been paid for those talks by Ferring Pharmaceuticals, EMD Serono, and the Oncology Nursing Society. Those relationships are since over. And I'm going to start off really just talking a little bit about stuff you probably already know, right? Adolescent and young adult cancer stats. So the NCI, the National Cancer Institute, designates an AYA as the ages of 15 to 39. What's super important is what's in this green box, that the 5-year survival rate for AYAs with cancer is now almost 86%. When I started a long time ago, back in 2010, this success rate wasn't that high. And, what we've seen is through more comprehensive programs, through better treatment protocols, we are increasing that survival rate specifically for our AYA patients. And when we look at the different types of cancers by diagnosis, this graph then really breaks down into very specific ages within that 15 to 39 cohort. So looking specifically at 15 to 19-year-olds, 20 to 29-year-olds, and 30 to 39-year-olds. And what you're seeing is in here is probably a no-brainer. So we see increased rates of breast cancer, not in our 15 to 19-year-olds, but really in our 30 to 39-year-olds. We see increased rates of colon and rectal cancer, again, not in our 15 to 19-year-olds, but really in our 30 to 39-year-olds. So even within this sort of AYA designation, we see very different types of cancer within really all the different decades of patients. Here at Northwestern, we have a very robust AYA oncology program. And when different organizations kind of got together to determine how do we make AYA oncology the best that it can be, they labeled out these 5 key pieces. And I, of course, highlighted fertility counseling because that's what I do. But, really kind of having a comprehensive program, we know makes a huge difference both to treatment as well as to outcomes. And if you've not seen the AYA program at Northwestern, this is Jenna Carrera and Bryn. They are just phenomenal, and they're really the heartbeat of our program, along with our psychologist, Stacy Sanford. They offer different AYA groups. They offer different, large Chicagoland area groups. So if you're not hooked up into the AYA oncology program within Northwestern, I would definitely encourage you to reach out to them and get put on their newsletter. So when we think about fertility counseling, there are a lot of societies who have all said the same thing, that essentially sperm freezing, egg and embryo freezing are standard strategies for fertility preservation in patients. And we should be talking about fertility and fertility preservation when patients are walking through our doors. So this is just a nice list of some really big agencies who have all kind of said the same thing. And kind of hot off the press is that AFON, CANO, and ONS, these are all oncology nursing societies, just put out a joint statement also saying we should be offering fertility preservation. So across the board, my hope is that with all these different organizations putting forth these guidelines, what we're seeing then in the clinic is that fertility is being discussed at the time of diagnosis, and fertility preservation options are being offered as well. So here at Northwestern, I really started, back in 2010 as the patient navigator. And the model of patient navigation is really about trying to get a patient from A to B to C in the most seamless and easy fashion. And so, for me, it's really seeing a patient initially at diagnosis, hopefully, talking to them about fertility and fertility preservation, getting them into treatment as quickly as possible, and then also being there on the survivorship side as well. And when I'm talking to patients, I'm really talking about gonatotoxicity, which is essentially a big word for how harmful is this treatment going to be to my fertility. And this is just a kind of an overview of very general terms, some very common treatments that we use in different cancer types, and what sort of toxic effect they could have on either testes or ovaries. And we'll kind of delve into that a little bit more. But, when I'm meeting with a patient, when I'm talking through things, this is kind of, the tables that I'm using in my head to kind of line out exactly what this toxicity looks like. And so when we think about male reproductive health, so individuals born with testes, I'm going to take you back to maybe what was 7th grade health class where you learned how sperm was made. But essentially in the brain, luteinizing hormone and follicle stimulating hormone help stimulate the Leydig cells in the testes. And these are the cells that then make testosterone. That testosterone helps to stimulate the Sertoli cells, which help with the spermatogonia cells, and those are the cells that actually make sperm. So anytime there is an interruption within this system, then that can have a negative impact on how someone makes sperm. And so when we look at the different cancer therapies that we're giving to patients, we know that chemotherapy in particular can really damage those Sertoli cells. So those were the cells that help those spermatogonia cells make sperm. We also know that chemotherapy can impact those spermatogonia cells. We usually don't see that testosterone levels are hugely impacted by chemotherapy, although prior to chemotherapy, you may have gotten a testosterone level check just so that there's a good baseline on hand. And when Dan Green, who is a researcher from St. Jude, when he was following his childhood cancer survivors, he looked at semen analyses in patients and was able to then also go back and see exactly how much chemotherapy did they have. And he uses something called a CED, or cyclophosphamide equivalency dosing. It's kind of looking at all these different alkylating chemotherapies and kind of putting them into a calculator so that we can come out with sort of one dose of how much chemotherapy a patient has had. And what he found was that sort of 4 grams per meter squared of, this cyclophosphamide equivalency dosing was really where we started to see a big impact on sperm production. So what this enables us to do is to have one common language then that all of us around the country can kind of utilize when we're coming up with different protocols, when we're talking about different options for patients, and really as well kind of how we're talking about counseling patients and when to offer sperm banking. Anytime someone's getting radiation directly to the testes, there's a concern that that can also impact those spermatogonia cells. But something we don't always think about is really high-dose cranial radiation. That high-dose cranial radiation can have an impact on the way that the brain makes luteinizing hormone and follicle stimulating hormone. And you really need that on the onset of all this to get the rest of that sort of flow going in order to make sperm. So if that piece of things is impacted, it can be really difficult for someone to make sperm after that. And we did a study here where we looked at our childhood survivors of cancer who are now adults. And what we did was just, kind of ask them about fertility at the time of their diagnosis. Who talked to you about it? Did anyone talk to you about it? What would you want to know now that you didn't know back then? And across the board, between both the now adult survivors and their parents, we heard that there was a lot of regret if it wasn't brought up, a lot of regret from the parents that they didn't ask about it, even though they didn't know to ask about it. And, kind of across the board, the adult patients saying, it's really important to me now. I wish that someone would have talked to me about it, or had someone talked to me about it at the time, I would have been like, yeah, if this is something my doctor thinks I should do, then I would have definitely tried to bank sperm. And, this was really published back in 2014. So now it's been a solid 10 years since that. And what we've definitely seen in that 10 years is that oncology providers are doing such a better job of talking about fertility at the onset of diagnosis, offering fertility preservation. And my hope is that that just really continues, and that continues to get better so that we don't have that same level of regret that a lot of these patients had talked about. So As a survivor and wanting to know kind of where do I go from here? What is my current fertility status? If you're someone with testes, then I would recommend that you see a reproductive urologist. And so I've put our reproductive urologists here for you, Val Brown and Bob Brannigan. Reproductive urologists are urologists who have had then specialized fellowship training on male fertility and infertility. And what they'll do is a full history and physical. They'll, look through all your medications, look through your cancer health history. They're going to order some blood work. Oftentimes that's follicle stimulating hormone, testosterone, prolactin, estrogen. They're also going to do a semen analysis, and that semen analysis will look at the total volume, so the total amount of ejaculate. It's also going to look at the sperm counts. Typically, there are a million sperm per milliliter. It's also going to look at the motility, which is how the sperm are moving, and the morphology, which is how the sperm are shaped. And then based on that information, they can kind of, talk through how this sample could be used in the future. And there's even something called DNA fragmentation. And this is where a sperm sample gets sent off to a very specialized lab where they're looking then at the DNA of the sperm itself to determine how fragmented that DNA is. And that kind of higher rates of fragmentation potentially could lead to higher rates of miscarriage, less rates of implantation of an embryo, less rates of live birth. So if there's some concern about sort of the DNA integrity of sperm, this is one test that can be done post-treatment to kind of look at those impacts. And interestingly, DNA fragmentation was something that was actually looked at in young adult cancer survivors. And they sent off sperm samples at the 12-month mark, the 24-month mark. And what we saw was when patients were even up to 12 months out of their last chemotherapy dose, we saw higher rates of DNA fragmentation within those sperm samples. Really kind of once patients hit that 24-month mark, we started to see that fragmentation go back down to where it was probably baseline. But I think it's an interesting thing to note that in most cases, most providers are going to say, please wait until you're at least 1 year out from your last chemotherapy dose before attempting to father a child. And it's largely due to this sort of DNA fragmentation stuff. There's a lot of sexual dysfunction that can go along with both cancer treatments and in cancer survivorship. And so this is another area that both Val and Bob can be such a great resource, to talk through, exactly what's going on, to offer some help and some remedies, and really to kind of make a plan for some next steps. So if, you're someone who's questioning your current fertility status, if you're someone who's experiencing any type of sexual dysfunction, I would really encourage you to find a reproductive urologist. That's going to be your best bet to kind of help guide you through all those next steps. We're going to switch it now to female fertility, and it's all about the follicles. So as women, you're born with all the eggs you're ever going to have. Sort of each egg sits within a follicle. Already by the time someone has hit puberty, they've already lost more than half of those follicles. And then what you see from puberty until really about, the early 40s is this sort of window of fertility. So this is when someone is ovulating eggs. This is when those eggs could be fertilized and a pregnancy could occur. We sort of have these years of subfertility, which is really from kind of early 40s to menopause, which in the United States is roughly about the age of 51. Those subfertile years are where there is some egg growth and there is some ovulation still, but really the quality of those eggs has declined so drastically that they're simply unable to be fertilized and then, grow into a live birth. So it's important to kind of note that unlike people born with testes, where there is this, typically sperm production occurring with every heartbeat throughout someone's lifespan, barring any, treatment that's wiped that out. When you're born with ovaries, you really don't have that happening. So there is this finite supply of follicles with eggs in them. And that's why age is such a huge, important factor when we're counseling patients about fertility and fertility preservation. And so this is just another way to look at this. So this is kind of showing you that same number of follicles that people have. And what it's really showing is like if someone has radiation or chemotherapy, and let's say they're 10 years old, so prepubertal, there's still going to be this loss of follicles, especially if it's really hefty chemotherapy, really high dose alkylating chemotherapy, or something like pelvic radiation. We see this sort of very dramatic loss of follicles. But, for most young adults, let's say someone's 30 and they were diagnosed with like a breast cancer or something, it's not that the treatment makes them infertile right away, but you can see it just sort of changes this curve. So it really means that they may have less time to get pregnant or to build a family than they otherwise would have, because essentially the radiation and chemotherapy has sort of pushed them down this line a little bit faster than they otherwise would have gotten there. And when we think about all the different treatments that we're utilizing in cancer, we're again really concerned about that follicular pool. We know that chemotherapy can make someone run through their eggs much faster than they normally would. So if someone comes to me and they're 38, let's say I'm seeing a 38-year-old and a 28-year-old, they have the same exact cancer, they're getting the same exact treatment, my counseling is going to look a little bit different because that 28-year-old likely has quite a few eggs still left in their ovaries and can probably weather some of that chemotherapy storm in some cases. Whereas for my 38-year-old who's already had quite a bit of loss of those follicles just from age alone, having additional loss of those follicles, additional loss of timing to pregnancy, my counseling is going to look a little bit different about chances of pregnancy status post chemotherapy. Anytime someone's getting pelvic radiation, there is a high concern, not only about those follicles. We know that radiation can do a lot of damage to those follicles and those eggs, but also the uterus is right there. So if a uterus has been radiated, it can cause some really drastic effects on future family building. In some cases, it may mean that someone's unable to physically carry a pregnancy because the uterus just simply can't grow and expand like it would need to. There are also other cases where, having pelvic radiation can lead to increased rates of miscarriage, preterm labor, low birth weight, and different placental abnormalities. So anytime someone's had pelvic radiation, we really want to ensure that we've hooked them up with maternal fetal medicine if the plan is to pursue pregnancy. Surgery as well is certainly going to have an impact on fertility. Interestingly, for a lot of patients who have had one ovary removed, that by itself actually doesn't seem to have a huge impact on whether or not someone can get pregnant. You would think that means that I've lost half of my follicles, right? And maybe, but it doesn't really seem to work out that way. So that remaining ovary kind of picks up the slack, grows the eggs that it needs to grow, ovulates out those eggs. In some cases, what studies have shown is that women seem to go through menopause a little bit earlier, maybe a year or two, than they otherwise would have if they'd had two ovaries. But for the most part, if it's just been one ovary removal and that other ovary is normal, then oftentimes, fertility preservation services are not needed. But it's when that one ovary has been removed and that remaining ovary then has some type of tumor on it or some type of growth, that's when we really want to get involved. And that's when we're concerned about that one last remaining ovary and kind of what's there. So back in 2006, which is now so long ago, almost 20 years ago, this was really one of the first studies that was done specifically looking at hormone markers during active chemotherapy. So these dark bars that you see here are active chemotherapy, and then all of these different hormone markers are sort of levels that give us rough ideas of someone's ovarian reserve. So AMH being one that you may have heard of, it stands for anti-Müllerian hormone. This is a hormone that's secreted by cells that help support follicles. Kind of the higher an AMH level is, sort of the more follicles that are sitting there within the ovaries. And what we saw with this particular regimen was that AMH levels within 3 months had plummeted down to almost nothing. And even when we're up at this 12-month mark, those levels were still really low. And so AMH being such a decent marker for ovarian reserve, if I have someone who is post-treatment and they've gotten an AMH level at, 6 months after treatment and it's low, I'm going to tell them to repeat that in 6 months, because really what it is sort of 12 to 18 to even up to 24 months after that last dose of chemotherapy, we can sometimes start to see a bit of a rise that wasn't captured here in this study. We also saw this drastic increase in both follicle stimulating hormone and luteinizing hormone in these patients. And what this is telling us is that the brain is working really hard. So the brain sort of sending that FSH LH signaling, and there just isn't any response from the ovaries. And so again, using FSH and LH along with estradiol is another really good way for us to figure out how the brain and the ovaries are communicating with each other. And we did that same study with adult survivors, kind of asking them as well, you know, what was talked about when you were first diagnosed? Talking to their parents as well. We saw that same level of regret, like, oh my gosh, I should have been asking about fertility. I should have been more thoughtful about that. And across the board, this was a very emotional kind of focus group that we were in, and it was patients kind of sharing, like, I wasn't given an option, and now I have to kind of live with those consequences of not ever been given those options or not having options at the time of my diagnosis because of either my need to start treatment or the options not being available. And also thinking about, where do I go from here? If I'm starting to date someone and I know that I can't have biological kids, when do I bring that up? Is that the first date? Is that the 6th date? Is it the 10th date? And so many other feelings that go into sort of being a young adult and having your fertility impacted by an existential crisis that you had no control over. So again, these focus groups were done a solid 10 years ago. So my hope is that it's much, much better now than it was back then. But I certainly know from chatting with patients all over the country that not everyone has these conversations with their oncologist before starting their treatment. And so when I'm meeting with the patient, I'm going to talk to them about fertility preservation options. So in some cases, trying to spare fertility with a surgery. So maybe not removing both ovaries, just removing one. Sometimes if someone's getting pelvic radiation, we can do what's called an ovarian transposition or an oophoropexy. This is where the ovaries are moved up and outside the pelvic rim to kind of avoid that radiation from hitting them. Most of the time, I'd say a good 50 to 60% of patients that I meet are going to pursue with egg or embryo freezing prior to starting their treatment. Across the street at Lurie Children's, they're offering a lot of ovarian tissue freezing, particularly to prepubertal patients who could not undergo egg freezing because they're not yet making mature eggs. So ovarian tissue freezing is where we remove one entire ovary. We save the cortex, the outside of the ovary. That's where all those follicles kind of sit. And we cut them into these little strips that you see here. Those strips are then frozen. And the hope is that in the future, we could take those strips, thaw them, and actually transplant them back to a remaining ovary within that patient. And to date in the literature, there have been about 130 live births reported. Likely there are somewhere around 200 plus live births that have occurred. We just don't have that reported in the literature. But that's certainly an option that a lot of prepubertal patients who we know are going to get very high risk therapy can now take part in. It was experimental until 2019 when they sort of removed that experimental label. But a lot of pediatric institutions will still really only offer this sort of under an institutional review board approved protocol. And then I'm also going to talk to patients about doing something like a gonadotropin releasing hormone agonist. So this is taking typically an injection during active chemotherapy that really quiets the ovaries and almost puts them into like a medical menopause. With the theory being that if the ovaries are quieted, then maybe the chemotherapy that's sort of attacking and destroying these fast-growing, rapidly dividing cells, maybe it won't see those cells in the ovaries and it won't do as much damage. And I purposely say maybe because the data supporting that are very mixed. We know that women who go on medications like this during chemotherapy maybe are more likely to get their period back after treatment. That's kind of one sign that the brain and the ovaries are still communicating. There's still something going on. But really, when they looked at pregnancy and looked at different cancer types, they didn't really see much of a difference. So again, it's there, it's an option. What it's really great at is actually stopping menstruation. So if someone's having really heavy menses associated with their treatment, that's a really great way to kind of stop their menstrual cycles. as a survivor, what should you do if you want to know your fertility status? So you can certainly reach out to your general OBGYN. That can be a really good place to start. They can kind of run some initial testing on you, and then they can also make referrals to people like reproductive endocrinologists. So here at Northwestern, that's the Center for Fertility Medicine. There's a large cohort of us that take care of patients. When you see a reproductive endocrinologist, what's going to happen is that they're going to want to do a history and a physical. They're also going to talk about any current medicines you're on, any past medicines, a detailed list of all the therapies that you were exposed to during cancer treatment, any type of surgeries that you've had. And then they're going to talk through next steps, and that's going to involve some diagnostic testing. So first and foremost, it's looking at labs, like I had mentioned. So anti-Müllerian hormone, follicle stimulating hormone, estradiol luteinizing hormone, likely going to want to do a transvaginal ultrasound. That gives us a very nice view of the ovaries and the uterine cavity. We can do something called a saline-infused sonogram, or an SIS. And what that does is inject some saline directly into the uterine cavity, and then we can see if it comes out of the tubes, ensuring that your tubes are open. We can also do that via an HSG, or a hysterosalpingogram. And we're going to talk too about genetic carrier screening. You may have had some cancer genetic screening done when you were first diagnosed. What this is something a little bit different. So it's looking at, something like 274 different genetic mutations that you may carry, and these are all typically recessive mutations, meaning that both you and the sperm source would need to be carriers of this particular mutation in order to pass that specific disease along to offspring. And certain ones that you may have heard of are things like cystic fibrosis or spinal muscular atrophy, that this sort of carrier screening would help see if you are indeed a carrier for that. And, if you're partnered or if you're using a sperm donor, if that person is also a carrier for that. If you have a partner that makes sperm, they're also going to talk to your partner about testing. So it's important to look and make sure that your partner's making sperm, that it's not just all about the female, making sure that, your partner's infectious disease status is known, making sure that, we also have looked at, all those baseline hormones as well, and then potentially made a referral to reproductive urology if necessary. And if at any point you're having questions or concerns about sexual health, or your treatment has put you into an early menopause, we are really lucky here at Northwestern to have the Center for Sexual Health and Menopause, really ran by Dr. Tracy Kurtzer and nurse practitioner Pat Handler. And these two are absolute experts when it comes to determining your current hormonal status and then finding ways to help you feel better. And if you're having any symptoms, if you're having any issues and sort of not getting the treatment or the answers to your questions that you need, I would really encourage you to reach out to this particular team. You can call their number directly. They also have an online website, and you can actually submit a request to get an appointment right on there as well. So when you're coming in to talk about family building with reproductive endocrinologists, they're going to talk through a whole host of options. So they're going to talk through ART, which stands for Assisted Reproductive Technologies. They'll, potentially talk about an IUI, an intrauterine insemination, maybe timed intercourse. Also likely, potentially talk about IVF or in vitro fertilization. They're also going to talk about additional family building options, and they're a great resource for these as well. So if you don't have any eggs anymore, they can talk to you about utilizing an egg donor. That's getting an egg from someone you know or someone you don't know. You can get fresh eggs, you can get frozen eggs. If you need a sperm donor, they can also talk to you about getting sperm, again, from someone you know or someone you don't know. There are multiple sperm banks that, we at Northwestern work with, but, multiple centers around the country work with different sort of agencies and different donors. They can also help guide you on embryo donation if that's something that you're interested in. If you needed to utilize the services of a gestational carrier, that's someone to physically carry a pregnancy for you because, you're either not well enough to do that on your own, or you don't have a uterus, or your uterus just isn't capable of carrying a pregnancy. This team can also help guide you through what that process could look like, and also even give some guidance on adoption or fostering. So a multitude of ways to build your family. I think when I see most survivors, they're really coming to talk about things like IVF and what IVF looks like. And IVF as a whole can be a lot. So it's injections that you take every day. It's frequent monitoring visits. Essentially, those injections are telling the ovaries to grow lots of eggs at once. Those monitoring visits are going to include lab work. They're going to include transvaginal ultrasounds. It's then undergoing an egg retrieval, which is an outpatient procedure done under conscious sedation. You don't feel anything or remember anything, but it's still a procedure. You still have to take that day off work. You find out that same day how many eggs you got. And those eggs, if you wanted them to be frozen at that point, they could be. Or you can also fertilize with sperm and make embryos. And that's kind of what this picture here is showing you. So this is something called ICSI, or intracytoplasmic sperm injection, where we're picking up one sperm, injecting it right into the egg to increase the chances of fertilization. And then we can grow those embryos out to a day 5 blastocyst. And at this point, if you're interested, we can actually biopsy out cells of what would eventually become the placenta and send those cells for genetic testing. And then the information that you can get back is varied. So you can get just the number of chromosomes in each embryo. And that kind of tells you, is this a normal or euploid embryo, or is this an abnormal or aneuploid embryo, meaning that there are extra chromosomes or missing chromosomes. If you are a known carrier of a gene mutation, so if you have Leaf Romani, or you've got a BRCA mutation that you carry, you can actually send that mutation, and that mutation, the genetics company can create an assay off of that mutation, and they can actually scan these cells against that assay and also give you information about these embryos and whether or not they too carry those particular mutations. So we're at a point with technology where you can really learn a lot as you kind of build your family through assisted reproductive technologies, if you want to. And so I just put up a slide of kind of like, oh, where do I go from here? So, I think it's important before you sort of seek the services of a reproductive urologist or reproductive endocrinologist to kind of have your thoughts together on family building. How many kids do you want? How did you envision building your family? What are things you're willing to do? What are things that you're willing not to do? And if you are having menstrual cycles and you've got ovaries, tracking those menstrual cycles, that's going to be something that, we're going to ask a lot about. There are lots of apps out there that track your menstrual cycles. Also, we're going to want to know about any menopause-like symptoms. Are you having hot flashes, night sweats? Are you having insomnia? And we're going to want to make sure that you're up to date on your general health, right? And I know after undergoing cancer treatment and being stuck in the hospital or stuck seeing your doctor so often, some of that general health stuff can start to fall off, but we definitely want to make sure that you're up to date on things like your PAP and your cholesterol screening and diabetes screening. We want to make sure that you're as healthy as possible before then, we talk about building a family and attempting, pregnancy. We make referrals all the time, not only to reproductive endocrinologists, but also to general OBGYNs. We also make referrals, especially for some of my younger patients, to what's called a PAG. That's a pediatric and adolescent gynecologist. So someone that's just had additional fellowship training in this particular age range of patients. So even, if you have a child who's, 15, 16, 17, or you yourself had never seen a general gynecologist and are pretty young, a PAG might be a really great place to go. And then too, as I mentioned before, our Center for Sexual Health and Menopause. I think before you go see someone, make sure that that provider is going to take your insurance. Most of the time, general screening should be a covered service, especially if they're utilizing proper diagnosis codes. And that's kind of what I put in here is that, if you're calling a fertility clinic and they're like, oh, we can't see you, first of all, call me and I can help guide you. But for the most part, those survivorship codes, cancer survivorship codes, or history of cancer, history of chemotherapy, those particular diagnosis codes really should then allow for coverage of a lot of these screening services. And we're lucky here in Illinois that we have a law about medical fertility preservation. So even if you're a survivor and maybe you didn't get to take advantage of this law, but you're guiding other, newly diagnosed patients. Illinois back in 2019 passed legislation that specifically said fertility preservation should be a covered benefit when it's due to something like cancer, due to some type of treatment that's going to negatively impact fertility. And if you don't have insurance that follows that state law, and that can be for a variety of reasons, or if you're in survivorship and this law doesn't now apply to you, there are still some really great advocacy organizations that if you don't have coverage, I would really encourage you to check out. So Team Maggie, Sam Fund, Worth the Wait Charity, the Chicago Coalition for Family Building, and Live Strong Fertility are all, some really great organizations. If you have questions about coverage across the United States, this is a really great map from the Alliance for Fertility Preservation. And this is a nonprofit organization that is really going state to state to state. And we wouldn't have this coverage without their support. Really making sure that bills hopefully get passed about medical fertility preservation. And so if you happen to live in a state where you see it's either yellow or it's white, and that means there's either inactive legislation or no coverage or no legislation, this could be a call to action for you. One of the ways that the bill got passed here in Illinois is because survivors came down to Springfield and met with lawmakers to describe the impact that their treatment had on fertility and describe how jarring it was to not have coverage for those services. So if you're in one of those states and you want to get involved, the Alliance for Fertility Preservation is going to be a really great resource for you. I'm also going to leave you with my contact information. So my name, again, Kristin Smith. This is my direct email. If you've got questions, you can always email me. You can also call me at this particular number. The fertility.nm.org is kind of our general fertility website, but also offers, a lot of additional information for you.